For those of you just joining us, we're probably going to wait just a few minutes. We heard one of the other sessions was wrapping up. So we'll join here probably at 1:03, 1:04. We'll start. So just received word that we'll start at 1:06. A couple other sessions are wrapping up right now, and folks are joining here. Next year, we'll invest in hold music, musical interlude. All right. Looks like we're at time. Thanks for everyone for joining us for this session today. We know there's a lot of competing sessions to participate in, and we really appreciate you joining us and giving us some of your time. Our goal today is to discuss EMR integration or interruption. And really the goal is to go beyond the technology and really focus on three core elements that drive successful and sustainable value-based care performance. It may be a little odd that we're a technology company at Curation Health, but we are humble enough to know that there's a lot more that goes into value-based care success than just the silver bullet of technology. There's a lot of investment, there's a lot of change management, and there's a lot of other infrastructure elements required to achieve long-term sustainable success in value-based care. And while we are highly confident and proud of the technology we built, we wanted to dedicate this time to talk about those other elements that are essential for long-term success. And I'm pleased to report we've assembled a great group of panelists today for our session. And we'll go through an introduction of the panelists, and then we'll talk about some of the key topics we'll be addressing. I'm Kevin Coloton. I'm the founder and CEO of Curation Health. I'm really glad to be with you today, and I'll be moderating today's discussion. And I'd like Dr. Lambert to introduce himself, and then we'll go through the other panelists.
Thank you, Kevin. Hello, everyone. My name is Matt Lambert. I'm the Chief Medical Officer for Curation Health and a practicing emergency physician by background. Happy to be here.
Thanks. Karen?
Hi. Good afternoon, everyone. My name is Karen Wilding. I'm a Senior Director of Quality and Value-Based Care for the University of Maryland Medical System, and also serve as our Compliance Officer for our Clinically Integrated Network and Care Transformation Organization.
Thanks for being here, Karen.
Mm-hmm.
Dr. Healy?
Good afternoon, everyone. Thank you for having me, and thank you for joining us. My name is Tony Healy. I'm the Medical Director of AdventHealth Medical Group, Shawnee Mission. We are a community-based provider-centric multi-specialty group. We employ about 100 plus providers for which we supervise. And in addition to that, we participate in a clinically integrated network called Centris Health, located in and around the Kansas City greater metropolitan area. So my perspective will be from the provider side.
Excellent. Thank you. So we're going to go through 3 topic areas of discussion today. And after this quick overview of our agenda, we'll have a quick overview of University of Maryland, AdventHealth, and then Curation Health, just to give you some context of how we're answering the question and the perspective we're using. But the 3 topic areas today are identifying the right data to use for value-based care. And when we define right data, it's actionable data, highly accurate, highly actionable, and useful in purposes of achieving value-based care success. The right care team, understanding that it goes beyond the physician that's documenting the encounter and adding a code. There's a lot of resource investment that can be used to augment performance and to support the physician in this journey. And then lastly, the right workflow. What is the process that maximizes performance in your value-based care, and how do you arrange the symphony of participants required to achieve sustainable and successful performance in value-based care? And we'll be focused on these 3 core areas as part of our roundtable discussion today. But first, from a contextual standpoint, wanted Karen to have an opportunity to give you a flavor for the University of Maryland and their infrastructure.
Thanks, Kevin. Just to give a little bit of background on the University of Maryland. So we are a large academic medical system that support all of Maryland. But what you have here is just a quick snapshot of the way that we've operated our clinically integrated network. I think a couple of statistics that sometimes are helpful so that you can kind of see, well, why is Karen framing things the way that she is? From a commercial contract standpoint, we work with over 5 different commercial payers. We have over 55,000 beneficiaries that we are managing. From a commercial, 28,000 of the 28,000 additional employee health. And we have about $590 million under management, expense under management from a commercial standpoint. In addition to that, and we work with over almost 400 primary care physicians across the state. You can see there on this map, there's over 80 different practice locations. Coupled that with our Medicare service line, which is another $585 million. We're over $1 billion in healthcare. We're well over 120,000 lives that we've been managing for the last couple of years. And several, we're well over 100 different practice locations and several hundred physicians that are actually in these contracts. So when I'm sharing perspective today, my thought process is operationally, how do you scale? How do you think through the work that we're doing, and how do we get people engaged and motivated to do the work that we need them to do, and change management? And then the other hat that I wear, I mentioned I'm the compliance officer. I'm always thinking of what are the unintended consequences. So as we're moving things forward, how is this going to impact our defense from an audit standpoint? How are we going to be successful from a revenue protection standpoint, and any other thing that could be thrown our way? So
That's awesome. Thank you, Karen, for being here. Your perspective will be valuable, especially in these three topics. Dr. Healy, AdventHealth.
Thank you, Kevin. So as I mentioned, I'm the medical director of AdventHealth Shawnee Mission Medical Group. So, I wear basically three hats in that role. About 50 to 60% of my time is spent as a clinician, so end user. Another 30% of my time is spent as the medical director, which, as you can see here, we employ about 150 multi-specialty providers, and we're engaged in a variety of different value-based and risk-based contracts. In addition, I spend about 10% of my time as the chair of the board of managers of Centris Health, which is our clinically network, which is a partnership of 42 different tax ID numbers, predominantly included in our hospital system, also the University of Kansas, which is the main academic center in town, and then finally another community-based hospital system. And we are on a variety, as you can see there, of other value-based contracts, including Medicare Advantage as well as MSSP. In total, we have about 120 to 130,000 lives between our commercial payers, which we have 4 contracts with commercial payers, plus our MA and MSSP plans. So there'll be a variety of perspectives that will kind of interweave in there, but I'll try to define which hat I'm wearing at any one time.
That's great. Thank you, Dr. Healy. We have all of our panelists have lots of hats. That'll add a lot. Dr. Lambert, Curation Health.
Yes, thank you, Kevin. Yes, Curation Health, we are a risk adjustment and quality platform that is focused on the fidelity of the information that we present to providers at the point of care. And so that focuses on the accuracy of the information and the integration with the electronic health record. And the way we do that is in our 3 C's. So curate, we have a rules engine with over 750 quality and risk adjustment rules that assesses patient information, clinical and claims, and presents that for a curation. We are as bullish as anyone on AI and technology, but we're still a firm believer that a clinical human review prior to presenting this to clinicians is key to our success. So we present that information 3 to 5 days prior to the visit. And when that's marked ready for physician, then we move on to the capture phase. And the capture phase, again, as I mentioned briefly, the APIs have come about so much where we can really focus sound clinical insights that map to a value-based care program at the point of care. And that means truly integrated at the point of care in the electronic health record, whether that be Athena, whether that be Epic, whether that be Allscripts, and really make it as easy as we can to allow the providers to act on that information. Then finally, the 3rd C is the confirm step, a post-visit pre-claim review of the accuracy of the clinical documentation and the diagnosis to make sure that we're really getting credit for the complexity that we're managing. And that allows a feedback loop in almost real time to get to shore up any shortcomings in documentation or diagnosis with that. So curate, capture, confirm, our 3 C's, ways that we really focus on help our provider partners make the shift to value-based care.
Thanks, Dr. Lambert.
Okay.
So we're going to kick off our discussion today focused on data. And we've seen a massive evolution in the availability of data, the volume of data, and the value of data from a value-based care perspective. And one of the elements here is the COVID-19 has dramatically challenged provider organizations in delivering care in both fee-for-service and value-based care paradigms. But the key question we want to discuss today is how do you ensure that the data you have on the patients at the point of care is the most actionable or important, understanding there's just so much available today? I think we'll ask this question to the clinicians first. Dr. Lambert, Dr. Healy, you want to start with how would you define the right data from a physician perspective?
Tony, I'll go ahead and go first, and we could probably talk. We won't, but we could probably talk the whole hour on this alone. But the right, I mean, just it's you can't understate the impact of COVID-19 and all of the good and bad things that are going to come from that downstream, and all the changes, right? All the things that we've learned and actually might benefit from this. But when I think of the right data, clinicians never signed up to be data managers. And most of us were trained, at least at my age, I don't know about Tony, but at least all of us were trained in an E&M world. So to support fee-for-service documentation. And most of us have tools that are built to support a fee-for-service note or an E&M level note. So at its heart, we're asking providers to focus on, maybe focus away from patient care and ask them to do something they weren't trained to do with a tool that they weren't trained to do it on. So one of the you really have to focus on the yearly changes, and COVID put everything out of sync this year, from changes from CMS with codes and changes with quality priorities. But first thing you have to do is to make sure that you are presenting the data that really means something, both clinically and in a value-based care world, to this patient and to the quality or to the quality programs. So we don't want to spend any time thinking this patient is an MSSP patient, or this patient belongs to the ACO, so therefore I need to do this. So simply filtering out a lot of the noise and helping the providers focus on the things that are going to drive the best outcomes and drive the best savings, I think is really important. And then secondly, before I go on too long, Tony, is getting that to the point of care. Asking a provider to log into a separate system, asking a provider to go outside of their workflow, their electronic health record, is simply a non-starter for a lot of times, and it's really going to limit your returns. So focusing on the right data and getting it into the workflow in the way that they can really act on it is the key. Tony?
I agree with everything you said there. One bit I'll touch on and reiterate is, the important data is the data that's going to drive outcomes. As it turns out, either intentionally or unintentionally, the actuaries who came up with HCC coding had a little insight into COVID, because as it turns out, a lot of those same data sets or data points, what have you, are also the drivers of outcomes for COVID, which works out relatively well for us. So that's one of the ways that we've kind of driven education on this, is that it's whether you're trying to impact costs or impact your risk. Really, let's just focus on impacting outcomes and preemptively identifying those patients who are high risk. And with that platform, you can train on HCC coding. I don't know if it's always going to be like that, but it sure, fortunately, has worked out this way in COVID. And we've been able to leverage a lot of our HCC data into pre-visit planning, or identify patients as high risk, identifying patients as candidates for monoclonal antibody treatments, for vaccine clinics, and risk stratifying patients, and all sorts of important measures that we like to think may have positively impacted the outcomes of our patients. Coincidentally, we may have positively impacted their risk to payers as well, which is quite fortuitous. But again, as far as right data, it's the data that's at the point of care that will likely drive their outcome.
That's great. And Karen, from a leadership perspective, anything to add from your view?
No, I think Dr. Healy, you hit on an excellent point. It was very interesting, as multiple use cases have come up during the pandemic. The question has been, how many asthmatics, how many patients are at this risk? Who has these kinds of patients? Where are they sitting? How many are we seeing? What's our capacity? And you can't answer any of those questions without the data. You just can't. And this actually shined kind of a light on areas where we said, well, we have that information, but it's embedded in a note, or it's not discrete. And so I think those were things that kind of were aha moments for some parts of the organization as we started to look at the data in a very different way. Public health emergencies and public health in general mandates use of data. And I think COVID-19 is really pushed healthcare around data collection in a way that we've never really been. And I hope for the positive. So Dr. Healy, you're spot on. We experienced the same scenario.
That's excellent. One more additional question for the clinician, for Dr. Lambert, Dr. Healy. One thing we typically see is great excitement with being able to capture data and a tendency to send all of it to the physician to sort through at a patient level or even a panel level. How have both of you approached that, trying to find the signal to noise ratio that works, that's sustainable? Because I think an important word that's appearing on this slide is a burden. I think COVID-19 has been a tremendous burden on the provider community, trying to manage all of the complexity and unknowns with this scenario. So how do you manage that volume to value equation? Dr. Healy?
That's a great question. I guess my answer there would be, as a result of some of our quality programs like CPC Plus, we have been able to deploy some really great care coordinators, some great social workers, some great diabetes educators, great CDIs, so a whole team of folks that I never thought I would have at my disposal. I was able to deploy with this data, and they were providing a significant amount of outreach to patients. Early on, it was just informing them, hey, in case you didn't realize you're really high risk, you really need to be super careful, which evolved into using those same data sets to providing outreach to get patients set up for immunization clinics, making sure that our highest risk patients were being immunized first. So, again, to answer your question is a great team of ancillary staff that I historically never would have had. But fortunately, in this situation, I have great social workers and care coordinators who I deployed to turn that data into impacting outcomes.
All right. Great. Well, so we'll move on to the next question, which is exactly a perfect segue from what Dr. Healy was referencing, is the team. Right. The question is, who should be part of your value-based care team and how best to optimize collaboration? I think the important context here is it takes a village to move from fee-for-service to value-based care, and what does the complement of that village look like? I think we'll start with Karen and go to Dr. Healy at Advent.
Well, team, it definitely is a village. And so when I think about the investments that we've made in our teams, both clinical and business, it's a variety of individuals with a diverse amount of skill sets. So not only do we have the role of the physician and of our clinical care team, and what I mean by that is our care managers, our social workers, our CHWs, our medical assistants in the practice. Every single one of them play an important part to pre-visit planning, to follow-up appointments, to referrals, all of the parts that are across the continuum. But then I also like to highlight, and these are the folks that kind of work behind the weeds with our team in the network, are the individuals who work on quality reporting or practice transformation, those that work in compliance, those that work in communications and get provider engagement. There are so many individuals that sit behind the scenes. And then, of course, there's the back end of office and the billing components. So coders and billers. And, I can tell you from implementing some of these programs, we've had to engage the registration staff, and it's something that I think people would go, what, registration? Well, yeah, if you want to get patients on a patient portal, you need to get your registration staff engaged. And in order to engage patients in their healthcare so that you can have them get the desired outcomes, patient portal is an excellent tool choice. And so that's one example where it really is a village. And I think sometimes when people think about value-based care programs, they think of the physician immediately. And rightly so, physicians are incredible. But we really like to think of it as a hub and spoke, that the physician is only one person and they only have so much time, bandwidth, and do what is needed to really achieve value-based care. So there's been a lot of investments in our organization, training, working to move people towards top of license, making sure that we had the right tools for the team. That's really important. And I think I won't say anything more about tools because we'll talk about that in workflow. So,
Thank you, Karen.
Dr. Healy.
Yeah, just to reiterate everything you just said, you touched on it. Everything from registration to revenue cycle. Everybody has an important role. Probably the one point I will add is making sure those roles are identified and defined so everyone has a clear understanding of what their role is. So that we can, and again, try to segue for you here, Kevin, as a part of that care team, there's some automation that is critical so that efficiencies are maximized by our team, which I think will help us kind of get into workflow here.
That's great. And from a collaboration standpoint, I think that's one of the most challenging aspects is all of these participants need to focus on their core role, but also many organizations, and I think Advent and University of Maryland are perfect examples, are living in 2 reimbursement models or maybe more. So how do you optimize the collaboration when your infrastructure is segmented between different models of both value-based care and fee-for-service, but also just process?
It is a daily change management exercise. So we are looking at physician compensation models, not to be confused with physician engagement models, right? So that is always an interesting conversation, but it's really about changing the culture of an organization and the fabric that sits within it. So we are top down and bottom up in many ways. And, we have support from our board that allows value-based care to be a tremendous effort in our organization. At the same time, we've had some listening sessions around the town hall and with some of our smaller groups to realize that we are not penetrating down to the level of staff and have the fluency around that collaboration. So you're highlighting a great point. Sometimes there are misfires or hot potatoes that are not caught because there isn't an awareness of people's roles. And it can be very challenging. It is a constant communication exercise.
Mm-hmm. That's excellent. Dr. Healy, anything from AdventHealth on that?
Yeah, you're right. It's other than just say it's a difficult and it's a delicate balance. Especially, and Karen, you can probably relate a little bit. As a employed medical director of a physicians group affiliated with a community-based hospital system. I talk a lot to payers about improving our ER utilization and our acute hospital stays and readmissions. But when I'm reporting to the C-suite, how bad do we really want to impact our ER utilization, et cetera? And so it makes for a unique balance to operate in all these worlds. But to me, I found a nice little niche in that coding applies to all of it. And if you can risk adjust effectively and you can code effectively, you can be successful in any of these worlds and not cause your CFO to bristle when you're trying to decrease volumes in the ER. So that's one way I've found to kind of operate with a toe in all of these little worlds as we dial down our fees for service and we have a greater palette for getting into higher risk-based contracts.
That's excellent. Thanks, Dr. Healy. Dr. Lambert, as a participant working with lots of organizations, what's your point of view on the right care team?
Yeah, I was going to interrupt you before you were kind enough to call on me. At Curation Health and also in our previous lives, right, with Clinnovations and the advisory board, had the privilege to lead a lot of change initiatives, and usually leveraged by technology. One of the things that I've learned from our time here at Curation Health is the message to providers that you're asking them to change, but you're going to put a team around them. Lands as well as any change message I've delivered over the years. So just really, I can't overestimate that enough. That we're going to do something different, but we're going to do it together, and each of us have a role, and there's going to be a team that's going to help us to do that. So I've really started to emphasize that as we expand across the country.
That's excellent. Thank you. The third question is workflow. And this one could be, I think this one as well could be an hour-long session on workflow. The question is how best to simplify the complete capture of patient information while also identifying your most at-risk patient populations and reducing the burden on the physician. And one of the key complexities here is once you've seen one value-based care workflow, you've seen one value-based care workflow. There are a host of them. And many organizations take very different paths. I'm really looking forward to hearing how University of Maryland and AdventHealth explore the definition of the right workflow. I think for this one, we'll start with Dr. Healy and then go to Karen.
So, and I would not try to claim that we've got the right workflow, but we have an ever evolving workflow that deploys the tools that we talked about earlier. Deploying our care team, defining roles within that care team, leveraging the information at the point of care while mixing some automation in there so it's not all done by our humans, so to speak. And making sure that it's given to a provider in a fashion that's already been chopped up a little bit so that it's not duplicative. It's given to them in a way that they can understand, digest, and make a quick decision that's accurate and timely and not have to rehash the same decision in the future. And hopefully that will help improve costs. If there's data we can help pull the data, and most importantly, that does positively impact patient outcomes down the road, either be it from improved quality, improved screening, improved risk stratification that helps us again drive immunizations or treatment measures. But it's an ever evolving topic, and I'm not sure we've got it right. We feel pretty good about it. I think we're heading in a good direction, but every day there's something new to learn.
Yeah, I think everyone is approaching this in an iterative fashion. I haven't heard anyone announce that they've got the holy grail yet. So we'll keep watching and learning from the evolution that organizations are taking. Karen, with the University of Maryland, how do you address the right workflow?
So we are very similar in that, as someone who spent 10 years in health IT implementing systems, I go back to basics, current state, future state. And I feel like we are forever asking that question. Where are we at? Where do we want to go? Where do we need to go? And what really has been exciting about this iterative process is the engagement. So I remember, many of you probably remember the first time you were part of a CPOE implementation, right? Maybe almost 20 years ago. People were like, what are you trying to do? Why are we doing this? And it's a very different dialogue now when we talk about implementing a change in a practice or in a hospital. People get it. They know the technology is going to help them. And so when we have future state conversations, it's almost as though members of my team are presented like, well, why can't it do this? And why aren't you able to connect X and Y together and make this easier? So the roles have changed in some ways where the clinicians are now much more fluent about the role that workflow plays and them being efficient. And being successful long-term and being able to do their work, maximize, where before they weren't as knowledgeable. And I think it's really an interesting and exciting way to think about the right workflow. So how we approached workflow, very different over the last 10, 15 years. And, University of Maryland, we're no different. It's constant, current state, future state. What do we need to do? And I will say, I like your note about at-risk populations. So this is an area that we use. We have a large EMR platform. We try to help with risk stratification and tools. We've got, other things out there, but I feel like there is no holy grail. Kevin, you've raised it, that it's really about having an investment in your tools at the point of care to really drive change. And that's where we've really been focusing.
That's awesome. I really appreciate the current state, future state analogy. And then those of us that have lived CPOE remember that time very well. So this is similar. Yeah. I think,
welcome. I love you.
Dr. Lambert, your point was on the workflow on the previous question was all about trying to figure out how to make things easier, more sustainable, and synchronized between participants. And we've talked about how iterative it is. you have additional thoughts on the workflow and what defines the right workflow for a particular organization?
Well, I'm gonna dig on Tony a little bit. Tony's a big Chiefs fan, right? Kansas City Chiefs, and as talented as that group is, we saw what happened back in the Super Bowl when they didn't do the basics well, right? And so blocking and tackling here is the key. So I would start when you think of current state, future state, or when you think of that, let's make sure we're doing the basics right. And so that's make sure the information is sound, make sure you don't have to spend time and energy validating what that information is, and making sure that it's as repeatable as it can be. So yeah, and I think once you get that in place, and once you start to iterate on that, then a lot of times the stakeholders will tell you what the next opportunity is, right? Or ways to improve. And now you're really in a cycle of continuous improvement. And that's and you know, Kevin, you're probably sick and tired of me saying common things are common, right? So you know, common workflow challenges are common. And so I think there's a lot to be learned from previous experience. And then common conditions are common. And I think, and common challenges are common. So focusing on those first, I think really sets you up for growing success over time. Sorry, Tony, I couldn't resist.
Well, just to make it a little stinger, you know, I'm from Maine, so I'm a Patriots fan. So that's really rough. That was really rough there, Dr. Lambert.
The fundamentals comment. Yeah.
Yeah.
So one of the things that's a huge element of the right workflow, and we talked about every organization is approaching this in an iterative fashion. We haven't done value-based care 20 years ago, and we have the dusty playbook that we're trying to restart with. We are, a lot of organizations are approaching this from whiteboard sessions of how do we use the infrastructure we have, the resources we have, and what technologies can we layer to facilitate scalability, efficiency, and effectiveness. I think one of the keys to the right workflow is change managing the entire chain is very complicated because your messaging is very different depending on which element of the chain you're focused on. Coders require different change management investments than physicians, than pre-visit chart review, than registrar. I heard MA, registrar, RN components. How do your organizations approach the multivariate change management required? Or is it just one message and people sign up and wear the jersey and proudly march on the field?
Yeah, I'll let you address that one first this time. Well, I fume here in my seat for no longer.
No, I'll go ahead. You know, to be leaders of a care team was not necessarily part of physician training. That's going to have to evolve and change. And those of us who have been asked to take those kind of roles, I think we've learned that on our own. So it's always a really good strategy to empower the physician champion to help push things forward. But having said that, you know, the message has got to be a little bit different for each part of each member of the team. And really, you know, and you got to put some humanity in this, right? We're asking people to try something new, right? And we've learned a whole lot about trying new things over the last year, right? As a society, or, you know, and so it takes some patience. It takes very careful messaging, takes some relationship building, and it takes iteration. But I think if I was going to start somewhere, I would ask the physician to set the tone for the change. I think that's a good strategy.
Yeah, I agree. I mean, you've got to have good physician engagement that starts with a physician champion, and hopefully that champion identifies their population effectively, or their demographic effectively, meaning, you know, people have heard this a lot of times. You know, this is an old advisory board saying about, you know, most of your providers are going to fall in one of three buckets, right? They're going to be the engaged, the disengaged, and those who are kind of on the fence. And hopefully your provider champions can identify those three buckets, get the engaged providers behind them, really work diligently on the providers who, and staff, it's not just providers, but any staff member, work diligently on those who are on the fence and hope that those that are disengaged will eventually follow either out of peer pressure or necessity. But that applies to the entire care team, in my opinion. But it does start with the physicians leading by example.
That's great. All right. I think that I'll just add one component to that and then just one more iteration of this question. I think it's workflow is so key for all organizations. I think one of my thoughts here on the change management of the chain of participants is it's a bit of a symphony. And I think the key is each participant, from our experience at Curation Health and helping organizations go through this change, it's understanding what role they play in the contribution to the whole equation. I think so often we just get focused on the task that I'm supposed to do and lose sight of how that interconnects with Dr. Healy being able to deliver a diagnosis to a patient that helps improve their outcomes. So weaving that together so people have visibility into their investments in the total. Always a sound strategy, but it's complex nonetheless. I think the last thing on this workflow component is, how have your organizations approached using information to determine at-risk groups and understand where the at-risk population resides within your communities? Anybody want to start with that? Or Dr. Lambert, you can start from how other organizations have approached this.
Yeah, I'll just, for better or worse, I want to start again with COVID, right? We, this time last year when we were all looking for ways to contribute, right? There were so many unknowns. And we started to see who was most at risk for a bad outcome from coronavirus. We realized that our provider partners had entrusted us with their HCC data or their chronic conditions, which were very well aligned with who was most at risk, and not only that, but who would most benefit from maybe home medication delivery, home meal delivery, who to help them prioritize subpopulations of vaccinations. So that was a real crash course in how to help manage a really short-term threat to a lot of organizations. So I think I learned a lot from that, and a lot of those lessons that'll be some of the positive things that carry forward from this experience.
Dr. Lambert, beyond what you just used as the COVID example, it really forced teams to come together in a way that they never had to. So we're talking a lot about some of the technical and the mechanics, but to get a little soft, right? Part of it's about the relationships. And what I found in making major changes in our organization, it's about the communication, but it's also about making sure that team members understand the value that their role plays in the bigger part of the puzzle. And so often members of like the medical assistant team will go, well, I'm just a medical assistant. And they don't always understand that their value is tremendous. It's scalable. And it impacts and has a direct cause and effect on our ability to be successful as a team. And when we are really effective in change management, people understand the value they bring to the workflow and to the process. And then they have pride in their work. And then you have adoption. And it's not until those ingredients really come together as part of your change management process. And I think COVID allowed us to illustrate that in a rapid life cycle, because people immediately saw the patient that was the diabetic come in, be seen, or get the meals delivered much faster than any population health exercise that I've experienced or witnessed. Rapid fire. So I think your note about COVID is a great, it's been a wonderful lesson for all of us.
That's great. Yeah, we have seen COVID to be the ultimate war game scenario for population health, right? I mean, it was an active requirement to understand how to deploy. And Karen, in your comment right now, I'm just reflecting on the fact that value-based care is one of the first opportunities to expand care outside of the immediate clinic room that the physician and the patient are present. where so much now is pre-visit analysis and understanding what needs to be addressed and planning for that care includes and is inclusive of a larger care team just by nature of having that analysis done outside and previous to the encounter. It's an intriguing concept from a change management perspective, but I think that's a great overview of workflow and how different it can be and how complex it needs to be, but ultimately it needs to be a symphony. And at this point, I think we've concluded those 3 questions. I'll ask the panelists if they have any additional comments or thoughts for the participants, and then we can move to question and answer. Great. All set. Elizabeth, we'll turn it to you to sequence any questions that you might have from the audience.
Thanks, Kevin. So feel free to enter any questions for our panelists in the chat. We'll give everyone a minute. We did have a question, Kevin. I know I heard Matt say that physicians are not data managers, and I heard Karen say that the physician is only one person. So what can organizations do to recenter physicians or refocus them to be successful for value-based care?
Good question. I think that's open to any of the 3 panelists.
Yeah, focus first on information, right? And even though you know we embrace the future of technology and AI and a lot of other things, we realize it's still not there yet. But a good use of technology is to, for lack of a better word, I use filter what information might be a priority for this patient. And again, that can be from a quality gap, that can be from a risk opportunity, or risk defined as a lot of different ways, right? That could be a risk capture or a social risk. And then once you have that information, find some ways where everyone can contribute in a way that matches their skills and matches their license, right? You know, patients will say a lot of things to their doctor that they won't say to any other member of the care team. But I think if you want the truth, you probably want to talk to what the conversation between the MA and the patient about what their challenges are with maybe transportation. So I think providing the information in a way that each care member can act on it, I think is a really good way to frame it up.
Karen, anything to add there?
I mentioned earlier the hub and spoke, right? So it's really about, and we, and all of our communication and marketing materials, we have the patient in the middle and then the care team around it. And I think, certainly giving information to all of them and leveraging the physician, but we choose to put the patient in the middle with all of the physicians, the pharmacist, the social worker, the billing team, all wrapped around it.
I think if I could add, Elizabeth, one of the things that I think about frequently is everyone is participating with the spirit of assistance in the value-based care team, and from a technology perspective in the vendor community. Everyone ultimately wants to help the physician and help the patient and their outcome. I think one of the challenges we face is really understanding exactly what help is required and adds value, because I think the risk is, without really understanding the workflow, the topic we just left, we run the risk of overwhelming the care team with data or overwhelming the care team with tasks and clinical activities. So being sensitive to the time available and the actual workflow that a practice is operating on is really important, I think, to recenter the physician as part of that equation, but then surround them with an effective team. The classic example is if you use a fee-for-service infrastructure for every element of your care delivery sequence, you can't suggest 10 suspect medical conditions in one 10-minute visit. Just won't work. So being sensitive to that and understanding that workflow and the constraints that exist, I think allow everyone to be recentered and feel like they can be successful. Because the worst case scenario is that they feel unsuccessful because they weren't able to get to everything, which is a pretty common occurrence clinically we hear from providers.
Sort of adding on to that, Dr. Healy, you've been a physician champion for Advent. How critical is that to the success of the adoption
Yeah, I think the most critical component to me is I always operate on the philosophy of education drives engagement. And if you help providers understand, you spend a lot of time helping them understand the why. Why do I need you to do this? Why are we looking at data? Why are we risk adjusting? Then that will tend to most positively impact behavior down the road most effectively. A great example that we've touched on a little bit here is social determinants of health screening, which in a lot of organizations is relatively new. It's certainly new to us. The providers were not interested in doing this. And we had to spend a lot of time, number one, educating on the importance, how we can deploy that information in the world of COVID and be mindful of all the other items that they had on their plate. And so maybe we need to deprioritize some of our other initiatives. Even CMS has been a little more wary and reduce the documentation burden on providers so that we can do more social determinant screening. We can do more of this risk adjusting and some of these data-driven measures that help drive outcomes. So it's happening, but again, education is critical, and being mindful and respectful of their plates are full. And if I'm going to add one thing onto their plate, there may be one or two or three that I need to remove.
Yeah, Tony, I was just going to add, sorry, Elizabeth, I was just going to add.
Okay.
Yeah, the E&M shift that happened last year, to allow a little bit more, I guess, rewards, complexity of decision-making, medical decision-making, and a little less on some of the other elements of it, I think is a step towards what we see some of our provider partners at Curation Health who, really set up their operations to allow for this, and we're talking a 60-minute visit, scheduled visit, I think is really a signal not only to the patient, but to the care team that there's this is the priority, and we're going to make allowances in how we work, to meet that. And I think for the provider organizations that can do that, I think you see them advance further down the value-based care journey.
So logistically, that 60-minute visit is a horse of another color and something we need a different hour to talk about. But
so true. Yeah. And being able to context switch between the visits. Yeah, no, it's tricky.
You're retraining healthcare. You are retraining healthcare.
Right. And that's one of the challenges we face is our infrastructure chassis of fee-for-service permeates every element of how most ambulatory practices operate, and calibrating and iterating away from that is going to be a journey for sure.
Yeah.
Thank you. We had another question. How important is technology to facilitate a value-based care workflow? Is it the one and only answer? I would like to take that.
It's critical. It is critical. It is not the only thing you need. If you have just technology, but you don't have engaged users, it'll sit on a shelf. We've seen it. It happens. If you have engaged users, but you don't have the right technology, then you have people who are not upset and not doing the work. So there's a careful balance between using technology to mobilize and help gain efficiencies, but there's also the role of the clinician and the care team that is critical to moving the needle.
Yeah, Karen, great point. Technology done well can be a good lever for change, right? But if you don't have the engagement around it or the why around it, as to Tony's point earlier, then you are just going to buy technology and it's going to sit on the shelf.
Yeah.
Otherwise, you'll be spending a lot of money on FTEs for all the CDIs that you have to hire.
Yeah. And I think one of the things, the element of the workflow is a big part of this, right? We when we're working with a new partner at Curation Health, one of the key things for our focus is workflow. How do you practice today? How do your clinics operate? Because ultimately, technology can make a bad process go really fast. And the goal is to make sure that you've optimized what you need to optimize to get the benefit that is promised with the technology, because usually there is some change required, either workflow, team member role change, or some enhancements of certain activities. And without them, it's, you have a fire hose that's blocked by a giant wall, and that's not helpful to anyone either. So key is understanding how technology can be used to enhance what's already there, or what needs to be optimized to really get any benefit from it. The worst case scenario is a capital investment that yields no value, that no one really enjoys that.
We have another question. Someone asked, can the curation team speak more to true integration at the point of care? What are the right tools and visual cues that help providers at the point of care?
I could start, and Dr. Lambert, you can add the detail. We define point of care. I think the challenge is the term integration is very, very broad and diffuse. Integration is anything from having a partnership where you can send data files to an EHR vendor, or it can be completely embedding your solution inside of an electronic health record. Those are very wide bookends. Dr. Lambert and I have the benefit of spending the last decade plus doing EHR optimization work prior to Curation Health. So it would be safe to say we're obsessed with provider workflow and clinical workflow. And so we went the route of being a certified partner of each of the major EHR vendors. So we are permitted to have access to their preferred APIs and allow us to use our solution that runs inside of the electronic health record. We believe that allows the physician to not even have to think about a workflow change. They are using their preferred workflow. Our solution appears as a feature within their preferred workflow in Epic or Cerner or Allscripts or the like. But we believe that's very important. If you ask it, the war is lost if you ask them to click a hyperlink or to go to a different portal. We just want them to have no inertia to be able to complete their clinical interaction with ease. Dr. Lambert, anything to add?
Yeah. First thing is the quality of the information. We've got and supporting this a lot in a couple different forums over the years. We have to minimize false positives. So we have to have high fidelity. So the providers have to trust the information. And it also makes sense, especially early on, to focus on those common conditions. Sorry to hammer on the common theme, on the basic theme, but common conditions that providers are comfortable managing, comfortable documenting on, and that we all know drives a lot of cost and utilization. So that's the first piece. The second piece is getting it in the workflow, and that takes a lot of. This is made possible by the maturation of the API over the last decade or so. Some electronic health records have more robust APIs than others. Epic has formalized and invested the most in their API program. So our integration with Epic is a part of the electronic health record and very tightly integrated to where the provider can see the insights and act on them very quickly. And then as you go to other electronic health records, there's a little bit of variance there. If we can't come in through the APIs, then we've learned to come in through the browser. We can integrate with your browser to where you get a pop-up alongside your electronic health record, as long as it's a web-based solution and the ADT feeds, and sorry, I'm getting technical here, but if the ADT feeds are there, then we can know when a patient who's attributed to a value-based care plan is going to arrive, and can present curated information through the browser. So it takes on some different flavors based upon the maturity of the electronic health record and the way that they are connected. But we try to get as close to workflow as we can, and we are continuing to learn more and evolve as we go. So yeah,
Thanks, Dr. Lambert. I just see we're at time, so I wanted to take a moment to thank Dr. Tony Healy from AdventHealth, Karen Wilding from the University of Maryland, Dr. Lambert from Curation Health, and the Curation Health team for facilitating today's session. Elizabeth, if people want to hear more, how would they find out information?
Yeah, feel free to visit our booth at RISE. You can email us at this contact information, follow us on social media. Our business development team would love to talk to you or send you a case study. And if you enter your name on our booth, you'll enter for a chance to win a $200 gift card. So thank you everyone for joining us today.
Thanks, everybody.
Thanks all.
Thank you guys. Have a great day. We appreciate your time.